First, I'd like to thank you for the invitation and share with you the experience that we had with a patient who's actually Dr. Felix Baez, whom you will meet during the opening session of the meeting a little later on today. And also to Professor Jorge Perez, who's a great doctor, Cuban doctor, who's the head of the Tropical Disease Institute in La Habana, who was key to the preparation and the training of Cuban doctors who went to West Africa, and also to the Henry Reeve Brigade, who was sent to West Africa to combat Ebola virus. So why were we concerned in Geneva University Hospitals in the context of Ebola? Well, we knew about the epidemic. We knew that there was the engagement of MSF, which has at least some Geneva headquarters. WHO has also headquarters in Geneva, so that the possibility that we might have to treat some healthcare workers coming back from Africa was not high at that time, but was possible at least. So as soon as April 2014, we started our preparedness in our hospital, and at that time, really few people understood why we would do such a crazy thing, because we were hearing stories about Ebola in West Africa, but certainly the epidemic was not full-blown by that time. So, but we constituted an Ebola cell, and thanks to the laboratory of our colleague here, Laurent Kaiser, the PCR test was really quickly available. And we started to collect and buy material and equipment in case that we had to have one of these patients. We identified a room dedicated to such a patient in the intensive care unit, and we started to train our ICU doctors and nurses, and also the emergency department, to different types of procedures that are specific for Ebola. We defined a room that was a single room, obviously, with a SAS at the end of the ICU, and we had also the possibility to look at the patient through windows from the room next door. And we started to prepare ourselves in this room. So this was the ICU isolation room that we had identified and prepared for receiving such a patient. And we started to do training and also simulation. And you don't recognize here, but it's one of the previous speakers, Manuel Schiebler, and myself, training in the room in a simulation scenario with Pauline Vetter here as the patient to make sure that we had appropriate training. We had also the chance to have a very performant lab in the hospital. There was a P3 lab to do the Ebola PCR. The context in August was that the Ebola outbreak was growing in West Africa. There was 2,000 cases reported. Healthcare workers started to be contaminated with Ebola virus, and also medivaced to different parts of Europe and United States. And so I remember that day in August 2014 when Dr. Margaret Chan, head of WHO, had her call for international emergency Ebola response measures, and that she stated that states should be prepared to detect, investigate, and manage Ebola cases. So one of the first nation who raised his hand was Cuba, and Cuba had really rapidly answered Dr. Chan's call and prepared the first brigade of 160 healthcare workers to be sent to West Africa. And maybe you don't know that, but Cuba has a long-standing tradition of sending healthcare workers for disaster through a brigade, which is the Henry Reeve Brigade, who trained 1,500 Cuban healthcare professionals that is readily available to be sent to disasters such as the Haiti or the recent Nepal earthquake. And also they are trained for infectious disease containment. So in October, a little more than 1 month after that call, Cuban doctors were the first, or among the first caring force in West Africa. What did Professor Jorge Perez in the garden of the Institute of Tropical Disease in La Habana is to reconstitute a field hospital close to what was found in Africa, just to train those doctors to be sent to Africa. And within 3 weeks, they trained 160 doctors. Now, the context in November was that there was a full-blown epidemic in Sierra Leone, Liberia, and Guinea, more than 11,000 cases, more than 5,000 deaths. There were new cases in Mali, Senegal, and in Nigeria. And Westerners, healthcare workers were starting to be evacuated to different European countries and United States. Just before the arrival of our patients, there was a contamination of a Spanish nurse who was caring for a medivaced patient. So that raised a level of anxiety and fear in our colleagues in the ICU, both doctors and nurses, that was relatively high. And we knew by that time that there was also a low availability of Ebola experimental specific treatments. So November 18, we got, well, there was a call from WHO to our Swiss Federal Office of Public Health to accommodate a Cuban doctor who was contaminated with Ebola in Port Loco in Sierra Leone, a doctor who started to have fever and symptoms 2 days before. So there was sort of an immediate acceptance by our federal and canton and also hospital authorities to have these patients under our roof. The patient was transferred by a dedicated aircraft from Freetown on November 20th, and he arrived at the airport that day in the middle of the night and arrived in the ICU at midnight, around midnight on November 21st. So that's our setting. We were just waiting for him. You see Dr. Schibler here, myself and the nurse, just waiting for the patient to come. When the patient arrived, Dr. Felix Baez was highly febrile. He suffered from encephalopathy with some incoherent speech. He was hypoxemic. He had cough. He required oxygen at that time. He had a swollen face, a capillary leak with conjunctivitis, and some signs of rhabdomyolysis, hepatopathy, hyponatremia, leukopenia, low platelet count, and a very high level of RNA copies of the Ebola virus in the plasma. He arrived with a central venous catheter in place and a bladder catheter, and as soon as 2 hours after his arrival, he received the first dose of the antibody ZMapp. This is just to give you sort of the atmosphere in that ICU setting, the way we were transmitting the results of the point of care between the room of the patient and the observation room next door. You have already seen that picture from Manuel Schibler's talk. This is a really rapid sort of summary of the clinical course of our patients who really did well very rapidly. So as as did the level of Ebola virus RNA in his blood. And he became negative after 10 days and remained negative until day 17 when we let him go out from our facility. Now we'll show you just a small movie of our setting while the patient was hospitalized. I don't think there is no need for big comments. Here is just the arrival of the patient during the night, the first night to the hospital. And then, as you will see, the room of the patient and how we perform dressing and undressing of the PPEs and stuff like that. So here we were in the room next door that had windows with the patient room, dressing.
Et quand tu les attaches, Steph, tu le fais au niveau de la cheville, tu ne fais pas trop, voilà, exactement.
Je pense que c'est bien, Rachel, tu revalides.
Moi, je dégage encore un peu plus. La racine partout.
Rachel, tu revalideras aussi.
Ouais, je vais valider là aussi.
Pour être sûr. Pour moi, c'est bon. Il n'y a pas de quoi, c'est bien. C'est des boucles de gaucher.
Voilà. Je te fais le petit nœud juste. Maintenant, je contrôle les contrôles. Je te dis là. Tu vas faire doucement les mouvements parce que c'est pas la peine de faire un truc brusque. Tu lèves un tout petit peu ta tête. Pas plus.
À tout à l'heure, les filles.
So we had a point of care in the room for most of the test, the blood test, except for the PCR that we had to do in the P3 plus lab. So here we are on day 7, around day 7. The patient is doing well already. So this is breakfast time. A lot of waste, around 10 to 15 of these trash cans daily.
Vous prenez quelle taille? Normalement, oui. D'accord.
So you recognize here the back of Professor Didier Pittet, who's the organizing person in this conference.
Prendre la cagoule au sommet de la tête, la retirer vers l'avant et la jeter. Posez les pieds sur le moltex en rentrant dans le miroir à droite.
Alors, Jérôme, tu te mets déjà sous le drapeau jaune, après on va mettre une image, là. Tu mets sous le drapeau jaune, et de là, tu vas quitter tes chaussures et tu vas mettre les pieds sur le tête.
And recognize our moderator in the back here. Okay, so what are we talking about when we talk about evacuated healthcare workers to Europe or United States? We're talking about 27 patients. 20 were medivaced from Africa to Europe or USA. 4 patients got actually sick while they were in Western countries and were admitted to Western hospitals. And we had 3 contaminations among Western healthcare workers, 2 in the US and 1 in Spain. Patients who had to be treated in the ICU, as far as I know, there were 12 or 13 patients, mostly in the US and some in Germany, Italy, Spain, and Switzerland. What was really helpful at that time, in November, at least when we had our patients, was a weekly teleconference that was organized among all the centers who had experience to treat medivaced patients. And I remember those evening when we were in Laurent Kaiser's office discussing with our colleague from Germany, Spain, Italy, and the US, and that was really helpful. So what are the issues that we had to face with Ebola patients in the ICU? So I think it's quite easy to understand that the contamination risk for healthcare workers is highest in that context because the patients might be bleeding, there are frequent blood sampling, the body fluids are highly contagious, and some of the very sick patients have a lot of diarrheas, up to 10 liters of diarrhea. There might be a need for invasive procedures such as putting central lines, intubation, dialysis. There were also a few complications of specific treatments such as convalescent plasma, and there are reports of that in the literature. And also, there are a big need for healthcare workers in terms of numbers that are needed to care for those patients. And we have to think, at least as the ICU director, of the impact on the other ICU patients of having one Ebola patient within the unit. So what are the specific ICU treatments in Ebola patients? And I'm sure that the next speaker will come back to that with a sicker patients that they had to treat at the NIH. But we might have to intubate those patients and put them on mechanical ventilation. Renal replacement therapy is actually feasible, and there are 2 reports in the literature, case reports that this is first feasible. You have to realize that the blood is in closed circuit, so there is no risk for contaminating the equipment, and you don't need to burn the dialysis machine after having treated the patients with Ebola. And people who have looked at whether the virus was present in the effluent, in the urine of the dialysis, it was actually negative. So it's not dialyzed. What we have to consider also in those patients is, and it's actually a big fear of co-infection or superior infection with bacteria, especially gram-negative bacteria. And there's some interesting reports in Germany of a patient who suffered from a very severe gram-negative septic shock who had Ebola patients. So you have to think about empiric broad-spectrum antibiotic therapy in those patients. And also complications of the treatment. The patients who have received convalescent plasma, there are at least 2 cases well reported of severe serum sickness and transfusion-related acute lung injury in those patients. And also, those patients suffer from a very severe capillary leak, and that's actually probably a big cause of mortality in Africa. And there is a new treatment that might be interesting in the future to combat that capillary leak. You have already seen that picture, but that was also a concern for us in the ICU, is whether we will end up with contaminated room or area around the patients, and all the samples that were taken and tested by PCR turned out to be negative, so that was actually reassuring. I think it's interesting to come back to last summer when this paper was written, was published in October, it was written in August, and Robert Fowler and Daniel Bausch had this statement in the conclusion saying that Ebola virus disease represents an illness ready for a paradigm shift in care delivery and outcomes, and the profession of critical care medicine can and should be instrumental in helping this happen. So in conclusion, treatment of Ebola patient is possible in ICU in Western countries, and as shown by Manuel Schieber, it's also possible to approach an ICU setting within centers of care in Africa. For us, preparedness was crucial. It's obviously a high risk for contamination of healthcare workers, and you have to work with that. In terms of psychology of the healthcare workers also. We can provide intubation, mechanical ventilation, and dialysis to these patients. We have to be careful with co-infection and secondary effects of specific therapies. Another very important point was the teamwork with other specialties. We cannot do everything as ICU doctors. We need to work in team with ID physicians, infection control physicians. What was also new for us is the relationship that we had to have with the media. We had a very big pressure from the media at that time with the first patient hospitalized in Switzerland. We have to think about the impact on our patients in the ICU and also work on team building and adhesion of the healthcare workers. I will finish up with this because we had to deal with the fear and anxiety of the ICU caregivers. And this is a note by Laurent Kaiser, who's here, who said, well, in the absence of exposition incident and without symptoms, there is no transmission risk to your family and kids. There is no need for protection during sexual relations, and kisses are allowed. Well, thank you for your attention. This is our team. Well, just part of our team, because we needed around 70 different healthcare workers to take care of that very precious patients of us who is here, Dr. Felix Baez. And thank you for the ID physicians and the infection control specialists who were among us to help us treat that patients.